Hi guys, can you hear me? Please post a message in the chat if you can hear me. Brilliant. Okay, we'll wait a couple of minutes for people to run through. Let's see. Okay. Just to check, if I'm clicking this, can you all see the slide? If you can put a message in the chat, that would be great. Brilliant. Thank you, Deborah. Okay. Okay, I see no benefit in waiting any longer. Let's begin. We'll just start with, this is the second session in Mind the Bleep final series, which is basically very UK MLA focused review of most psych conditions and presentations that you'll see in your exams and that you'll encounter in medical school. Now today we'll be focusing on depression and anxiety, and within that there's a couple of subsections I'll be focusing on as well. But the aim for this is really to gear you guys up for the exams, and it's very exam orientated. If you would like more of a sort of holistic approach to these conditions, just ask questions pertaining to that on any individual slide or any individual condition we go over. But most people are here to do well in their exams and to learn for their exams. So I've made sure it's as concise as possible and focused on that. So without any further ado, I think I should just wait. I'm getting told to wait until 7:05 to start, so that's what I'll do. Another 2 minutes. So I've also tried to make it as interactive as possible. Let me see, I'll just sort out a few polls while I'm here. Okay, that should do it. Okay, fine. The last one is good. Okay, that's all done. Let's start. Okay. So, in this presentation, we'll cover so depression and generalized anxiety disorders are the main things, but also PTSD and OCD, and differentiating between the acute stress reaction and post-traumatic stress disorder as well. Okay, next one. So, in the chat, can someone put the core symptoms of depression? Just looking for some core symptoms. You can put anything down, any symptoms of depression that you know. Low moods, okay. Anhedonia, yes. Anhedonia, good one. So these are basically the two most common, the two core symptoms of depression that Ruble and Deborah have got. So, low mood. So what do we mean by low mood? We mean someone who, you know, it's a self-reported assessment. Usually, you can get other people can report it as, and it can be objectively verified via mental state exam. But the key thing is the patient reports themselves to be in a low mood. Anhedonia is basically not feeling like you have any enjoyment out of the things you used to enjoy, or you don't have any interest or pleasure in doing things you used to like. So in the GP setting, a patient comes to you, and you might suspect this. There's two main questions you need to answer. You need to ask, and these are related to the two core symptoms. So during the last month, have you been feeling? Have you been often bothered by feeling down, depressed, or hopeless? Or the second question, have you been bothered by feeling having little interest or pleasure in doing things? And as you can see, these are reflective of the two core symptoms, low mood and anhedonia. And these have to be, according to ICD-10, which is what your exams are based off of, they have to be for more than 2 weeks to count as depression. Okay, so in an OSCE situation, when you have a depressed patient, it's very important to remember to risk assess this patient. So risk assess them about the risk of suicidality. Ask them, have you ever felt like taking your own life, or asking about self-harm? Have you ever engaged in self-harm behaviors? And there'll be an OSCE session arranged by Mind the Bleep at some point in the year as well. Which we'll go into that in more detail. This session is not for that, but if you do have any questions, put them in the chat. So in depression, you also want to take a forensic history in OSCE, so a history of abuse, violence, which is can be common triggers for depression, as well as certain medications, certain drugs, which can precipitate and perpetuate depression. One thing is social support, which always get missed out in OSCE. People always forget to ask about, take a good social history from depression. Is very, very important because it's one of the preventative factors, social support, and one of the key ones actually. So there is one questionnaire you should know for depression, the PHQ-9, and it's on the next slide. But very simply, the clinical relevance of this is that if it's less than 16, so you might have a question for example, the PHQ-9 is 14, what would be the first line treatment of this patient? And if it's less than 16, NICE recommends against antidepressants, so SSRIs and the like, unless the patient wants them. Okay, and there's also a small thing about MSE answer, which I'll get to. MSE standing for standing for mental state examination. Okay, next slide. Okay, so this is the DSM-5 criteria for major depressive disorder. So it's obviously the exam is based on ICD-10, but it's very helpful, and there's a lot of overlap. So a sad face is really easy way to remember it. A, appetite weight change, which is targeted with some medications, which we'll see. S, sleep insomnia, sleep disorders, and that's also targeted. Usually insomnia, or you can get both insomnia and hypersomnia as both common presentations. Anhedonia, we talked about. This should say dysphoria, which is again sadness, fatigue, feeling agitated, etc. Okay, just a handy way to remember. Okay, this is the PHQ-9 questionnaire, and as you can see, it asks about all these kind of symptoms that we just touched on, and this is the assessment that's given. That is the gold standard of depression assessments. Okay. Okay, so this is it's a good way to differentiate certain conditions which might have similar presentation. I mean, when you read about, I'm assuming we know what delirium is. It's acute confusion, usually secondary to hospital settings or new medications people have taken. Dementia and depression. These are things which sound very different in when you're reading them in a textbook, but in practice they actually can present very similarly. And one thing I want you to remember on this is that in depression, usually they have cognitive assessment scores of 0, or it's very common for people to have cognitive assessment scores of 0, because instead of answering questions, they'll just say, I don't know. They'll have a reluctance to engage. And this is actually a sign of depression, but it can be one of the reasons why patients who come in with depression are maybe misdiagnosed with dementia. Okay, this is a question 2. It's about treatment of depression. So you're an F2 working in community psychiatry, and a man he presents to your clinic 9 months after a heart attack, myocardial infarction. Since his heart attack, he's been feeling low in mood, he can't concentrate, and he has no appetite. He's tried online CBT with no effect. He does not see the point in living anymore, as he gets no enjoyment for life and feels like a burden to his family. So you decide to start on medication. What would be the most appropriate to start with? So I'm just gonna get a poll here. You guys should, if you guys could answer that, that'd be great. Okay, we're getting amitriptyline, citalopram, sertraline. Okay, fine. Fine. Any more? That's fine. Okay, so the the answer is, well, it's not. Well, we all know that SSRIs are usually first-line medications. Going through it, I don't know why. TCAs aren't really commonly used. Citalopram is a good answer. Fluoxetine is another good answer. Bisoprolol, I'm glad no one put it. That was like the easy answer to rule out, and sertraline as well. So you can notice there's 3 SSRIs here. So if we just go to the next slide, then the SSRI you want to have post heart attack is sertraline. That has the most studied SSRI, and it has the most efficacy in that. And that's a very common exam question. It was actually taken from a question bank, this very question. And the key thing about this is that he has multiple symptoms: low appetite, low mood, etc. He's tried cognitive behavioral therapy. He is clearly depressed, and he's had a myocardial infarction. So that's indication. Post MI is indication for sertraline. So usually, as you guys would know, SSRIs are the first choice. Fluoxetine or citalopram are the most common. Fluoxetine in children, especially. And citalopram is another very commonly prescribed drug, but it can have cause issues with the heart, with the long QT interval. And with this long QT interval, it can cause other issues like torsades de pointes. And it's very commonly in psychiatric settings co-prescribed with haloperidol as well, which can further precipitate QT issues and heart issues. So that's one thing to watch out, especially if you're doing your PSA. That's an inevitable question. So now you're in the community psychiatry setting, for example. You start a patient on SSRI, and one of the things about SSRIs is they have a very unhelpful side effect profile. So in the first 3 weeks after starting any SSRIs, people have an increased risk of suicidality. Now, for that reason, within 2 weeks, all people should be reviewed, and if they're under 25, obviously at higher risk for suicidality and suicide, then it should be within 1 week. Generally, SSRI courses are very long because they should be continued for 6 months after symptoms resolved. So a common question is, the patient is now feeling better. How long can they stop their medication? And the answer would have to be 6 months after the symptoms resolve, if that makes sense. Okay, this is a common topic and research interest of mine, which is SSRI discontinuation syndrome, which is basically withdrawal, but it's not explained like that in medical school that often. It's basically withdrawal of SSRIs, and that's why gradual tapering is so important. So that's the first bullet point, is just for people's information. If you want to, it's quite interesting if you want to look it up. It's not really clinically relevant. But what is relevant is that you have to taper it over a number of weeks to months, really, especially for longer courses. And that is because, you can get these kind of really odd symptoms which pop up as a result of tapering it too quickly. And this can even happen in the hospital setting when people forget to prescribe the patient's regular SSRIs, or they hold it at the beginning of the admission and they don't restart it. And this can cause all sorts of sleep issues, can cause all sorts of sensory issues, nausea, and can cause a very weird electric shock sensation, a paresthesia, which can feel like electric shocks running up your arms. And this has caused many problems with people who drive like heavy goods vehicles for work and that sort of thing, or or heavy machinery, or who operate heavy machinery. But that's something definitely to be aware of, is the gradual tapering. Now, fluoxetine doesn't need that gradual tapering, and that's precisely because it has a much longer half-life than the other drugs. So the half-life is 7 to 14 days of fluoxetine, which is massive. Okay, now the second poll is, which of these is a side effect of SSRIs? Let's get that on the poll. Okay, so some people are saying NMS, hyperkalemia, hyponatremia. These are all good attempts. Okay, that's fine. I'll stop that there. Okay, so the answer is hyponatremia. All right, it can cause hyponatremia, and SSRI side effects are a very important part of prescribing SSRIs and knowing about SSRIs. And this is where a lot of exam questions will focus in on. So it can cause nausea and vomiting and diarrhea, which actually can precipitate hypokalemia, not hyperkalemia. Headaches, loss of libido is a massive one that's reported by a lot of people who start it. Sometimes like 40-50% of people. Low sodium, serotonin syndrome as well, which we'll talk about further in. I'll talk about briefly here. And increased bleeding risk, because basically serotonin is very important for platelets, and you have less serotonin reuptake, therefore platelets don't work as well, therefore you don't get good clotting. And now this really, if you understand it from this point of view, then you can really understand interactions very easily. So any interaction question will be very simple. That triptans like sumatriptan and other triptan drugs, rizatriptan, have very high levels of serotonin as well, and that can precipitate serotonin syndrome. But if a question comes up on serotonin syndrome, it will be inevitably about the interaction between monoamine oxidase inhibitors, MAOIs, and SSRIs, because this is the most fatal interaction. And it's like drugs like selegiline, rasagiline, these kind of medications. And it can precipitate serotonin syndrome. Another interaction is NSAIDs, obviously for gastric ulcer bleeding risks, which you would have PPI for cover, omeprazole, lansoprazole, that kind of thing. And warfarin, heparin for the bleeding risk, in which case you would give the NASSA, the NASA, which is mirtazapine, and aspirin as well for the antiplatelet effect would be relatively contraindicated. Okay, so just to very brief points about other medication classes is SNRIs, very similar to SSRIs. Just remember that in really bad hypertension with like above 160, above 170, 180, you would want to consider holding it. And in completely uncontrolled hypertension, it's absolutely contraindicated. And this is because of the sympathetic effect on the nervous system that SNRI has. Now, TCAs, tricyclic antidepressants, are not used anymore. They used to be a mainstay, but it's worth just knowing that they have caused massive heart problems, like bundle branch block and all sorts of stuff, and cause dry mouth, constipation, blurred vision as well. So they're not very popular with patients either, which are all anti-muscarinic effects. Now, NASAs, and this is a very popular question about NASAs that come up. What are the what are the effects of NASAs? There's two main effects and two main reasons why mirtazapine is prescribed, and that's because if patient has reduced appetite and they are having real trouble sleeping. They're insomnic and they have reduced appetite, and that's why it's called mirtazapine, stressing the M's and the Z's for the hunger and the sleep, obviously, and that's where you can remember it. Depression is not often, most depression is not often treated with SSRIs or any type of pharmaceutical medication, pharmacological medication. It's recommended, first of all, by NICE to only do it after a lot of other options are exhausted. And this would be stuff like guided self-help. So this is taken from the NICE list, the NICE criteria. The one they recommend first is guided self-help, and then group CBT, group behavioral activation, which is basically just being mindful of how your behaviors are being triggered and what behaviors you're using. And CBT, I'm assuming people know, stands for cognitive behavioral therapy. And it basically goes from least resource intensive, which is something you can do by yourself, guided self-help, to most resource intensive individual CBT. Now, it's also worth noting that there is, for refractory depression, especially in postpartum depression and other types of depression, which are very, very intransigent, very, very stubborn with medications, you can do electroconvulsive therapy as well. And always some side effects that might seem obvious would be headaches and also short-term amnesia. Okay, I'm not sure it says a 5-year-old man. It's supposed to say a 50-year-old man. So let's pretend it says a 50-year-old man. But yeah, so it's now moving on to anxiety. So 5-year-old man presents to his GP with a 6-month history of excessive worry about various aspects of his life. He's feeling restless. He finds it difficult to control his anxiety, etc. What's the most appropriate first line immediate management? And let me just stop pause for this. Okay. Surgery, and someone's put surgery. Education, okay. A lot of people have put sertraline. This is a good, it's a good guess, but actually, this is the So the most appropriate first line immediate management of this would be to educate the patient about generalized anxiety disorder, and that is recommended before sertraline, which is the next stage. Now, I've underlined various parts of this question. So 6-month history, excessive worry, various aspects. He defines it difficult to control his anxiety, reports feeling restless, easily fatigued, difficulty concentrating. Mild, so the mild is the key thing, which would clue you into the education rather than the sertraline, if that makes sense. And then no past medical history. And I've also asked about thyroid. So things to think about this is, why do we ask about thyroid tests? It's because hyperthyroidism can precipitate a lot of psychological behaviors like anxiety and feeling on edge, etc. What other conditions do we want to rule out? Stuff like pheochromocytoma, Cushing's disease, and what drugs could cause these symptoms. So drugs like caffeine, drugs like cocaine, and in terms of withdrawal from alcohol, withdrawal from benzodiazepines, like diazepam, can often cause these symptoms as well. Okay, so generalized anxiety disorder is defined in the ICD by excessive worry greater than 50% of the time for more than 6 months. So there's two kind of sides to this. There's the emotional side and the physical side as well. So the emotional symptoms of generalized anxiety disorder would be like fatigue. As mentioned, the patient feels difficult to focus in on tasks because they're worried. And something really to take note of is that one of the alternative causes is bronchodilators. So like SABA inhalers can precipitate anxiety as well. And so pheochromocytoma, I talked about hypothyroidism, Cushing's, and steroids as well. So prednisolone, and that's because of the adrenal activity. For patients under 30, this is a question which I've seen in some papers as well, that it'll ask you, this patient has come in, they have this history, when should the next weekly follow-up appointment be? And it should be in the next week if they're under 30 because of the suicide risk. Okay, so treatment, this is what we talked about in the previous questions, that education is first, and then guided self-help, and then CBT and drug therapy. And in drug therapy, you guys were right, sertraline, that's a great answer because it's the first drug that should be considered, but drugs are considered right at the end, towards the severe end of the management pathway, because obviously this is not a pharmacological problem with the patient. It's not a chemical imbalance particular condition. It's caused by various stresses in their life, and that's why sertraline is only for severe cases, and then different SSRI, and pregabalin is used in refractory cases. There might be a question like sertraline has been used, different SSRIs are being used. What should be the next thing they try? And pregabalin would be the answer. Propranolol is often used to treat the physical jitters, like before speech or before some sort of talk. People with generalized anxiety disorder would be offered propranolol if they ask for it. And asthma is something to worry about in this condition as well. Diazepam is often used in the acute phase only, I've heard, according to NICE, but they're not really used at all because of the risk of addiction to the benzodiazepines is very, very severe. And ironically, withdrawal from benzodiazepine can precipitate anxiety as well. Okay, so the next topic is PTSD. So what I want to hone in on PTSD is three main core symptoms, right? So as I've mentioned, a typical history would be, and this is what you'll see in the exams, that you'll have a road traffic accident, some patient getting assaulted, getting robbed, and then they'll be experiencing things like flashbacks, nightmares. They'll be doing that re-experiencing. They'll be feeling on edge, feeling restless, and they'll be trying to avoid being in the same place, or, for example, driving if it was a road traffic accident. So those are the three core symptoms according to the diagnostic manual. And for PTSD, you have to remember that it's above 4 weeks, whereas with acute stress reaction, it's much the same condition. It's just under 4 weeks. There's not really any difference, to be honest. And that makes it quite easy to, if you think about it like that, it's quite easy to differentiate. So acutely trauma-focused CBT is offered, and benzos for sleep. And obviously, if it goes above that 4-week threshold, then you would start considering trauma-focused CBT as well, and medications as well, like sertraline or venlafaxine, which is very commonly given in this condition. Risperidone is an antipsychotic and is used to basically calm the patient if it's very severe. There's also EMDR, which is eye movement desensitization and reprocessing, which is something that's really cool. Actually, it's basically it's when but you have like a it's done with, it can be done with a psychiatrist or specialist psychologist, I think, and it's basically when they make you look in different directions, and they change your eye movement in different directions, and they focus on bringing up the memories at the same time and trying to like desensitize you to what your eyes usually would do. It's quite a new and bit esoteric treatment modality. Okay. The next thing I want to touch on is OCD. So OCD is a very common and very well-known sort of condition, but it's really not what it's known as in the public perception. It's quite different. And just to hone in on the two main obsessions and compulsions, you'll see patients come in and they'll have, typically in the in reality or in exam questions, they'll have things like they feel dirty, they feel when they touch the doorknob that they're unclean, they feel that everything needs to be symmetrical around them, things like that. And then they'll have compulsions, which will be based off those obsessions. For example, washing their hands repeatedly if they fear germs, and often these ritualistic behaviors can be triggered or by something in their life, some traumatic event. So, for example, COVID caused a lot of patients that we saw to have germ-related OCD and worry about spreading that to their family. And one of the difference between OCD and a lot of other psychiatric conditions is that people with OCD generally have more insight into their condition. And they'll know that what they're doing is not logical or it's not normal, but they can't really keep themselves from doing it. They are compelled to do it. And the treatment of this is twofold, really. It's the CBT side of it and the medication side of it, which is basically a common theme now. So ERP is exposure and response therapy, which we'll talk about in the next slide, and then medication is SSRIs usually, and clomipramine for refractory presentations, which is a tricyclic antidepressant. Okay, so this is ERP, and this is basically what CBT with ERP would do. You would identify triggers, for example, in a patient who is they have an obsession about being clean, and they don't like to touch doorknobs, or they feel unclean when touching people. You'll have a picture. a picture of a doorknob, or you'll structure their beliefs and their behaviors in a sort of, this is what triggers them the most, and this is what triggers them the least. And you'll start from the least and you'll go to the most. And that's guided exposure through the different realms. And then the thought behind it is that if you can refrain from touching a picture of a doorknob, then it'll be easier to stop touching an actual doorknob, for example. All right. And thank you for listening, and please complete the feedback form. Any questions from any of that? Brilliant. Okay. Thank you. Okay, brilliant. Seems like there are no questions. Thanks very much. Thank you.